Okay. So as we're starting, we're gonna make sure we start on time for renal pathology rounds. People will probably continue to join. I think we had like 20 people attending. Housekeeping materials. I do notice that some people are not getting added to the invite list, or they had been on the invite list and then something happened and now they're no longer on the invite list. So I say every time, if you go a month and you haven't heard anything from an invite, then it's a good idea to reach out to me and see if somehow you accidentally were kicked off the Outlook invite list. I know Dr. Foster, who is, one of our colleagues that attends almost all the time, accidentally got kicked off at some point. So don't be shy if you are wondering where the invites are. And then today we have a pathology resident at NC State, also working at UNC as well, who's presenting. And so if there are cases that you are interested in and you are the clinician that did the biopsy, or maybe one of your residents did the biopsy, or if you're a pathology resident and you have a really cool case and you want to be more involved in presenting renal pathology, anybody can request a case or ask to present the case themselves. That way we keep everybody involved. And then they are recorded, and Dr. Foster has been keeping them uploaded on the YouTube channel, I think is what he calls it. It's pretty easy to upload the materials. I'm told it's password protected so that people can watch these later. And as the nephrology and urology specialty program is underway and being launched, a lot of this material can be used for teaching when it comes to the pathology part. So that's exciting and at least a little bit helpful to already have some background showing histology lesions, possibly showing electron microscopy and immunofluorescence. So Dr. McGinn, I will turn it over to you. I'm going to mute myself and quit my video, but I will pop in if I need to.
Okay, thank you so much. As Dr. C said, I'm Dr. Peter McGinn. I'm finishing up first year comparative anatomic pathology resident at NCSU and also at UNC. And I was really excited to present this case that I got on the necropsy floor. But I want to preface with two things. One, I don't have a definitive answer, so it's going to feel like I'm leading you somewhere, but I am just leading y'all into the great unknown. And then two, I am very much a budding renal enthusiast, so I have a lot to learn. So I'd appreciate any feedback. And yeah, all right, without further ado, let's get into the case. So this was a 1-year-old male neutered Boston Terrier, had a history of chronic renal failure of unknown etiology. Fortunately, no further history was obtained due to the owners being in emotional distress, and no diagnostics were performed. So I don't have a lot of great blood work or clinical correlates. And the differentials were largely everything under the sun, from congenital to toxin to neoplastic. This is not the dog. I just thought it would lighten the mood a little bit. So I've got some gross images coming up. Here we have the two kidneys, and they're bilaterally symmetric, and hopefully you can appreciate that in the cortical area, there's sort of this miliary and granular pattern all throughout. Can y'all see my mouse, Dr. C?
Yeah, we can see it.
Okay, thank you. So you can see there's these granular and sort of miliary pattern all throughout the cortical region, and it's repeated on the backside too. So there's this pattern, I guess, in the cortex. And then of note, here we have our pancreas and our duodenum. You can see the duodenal wall is really edematous and thickened. And then the stomach is edematous. There's mucosal hemorrhage as well as some mucosal ulceration, which I try to demonstrate here, as you can see this depressed focus. And then I know I'm committing the cardinal sin of touching the mucosal surface, but hopefully you can appreciate that thickening and edema in the gastric wall.
What did you think about the color of the kidneys?
I can't remember the food contents, but it is very yellow.
Sorry, no, of the kidneys themselves, so the cortical.
Kidneys. Yes, sorry. Yeah, there were. I think there was some increased pallor for sure. But I don't know, did you notice something?
No, I was just, you know, so for people who don't do a lot of autopsies, this might be an acceptable color for maybe a cat kidney, because cat kidneys have a lot of pallor in the cortex. They often accumulate a lot of lipids, so there's a little bit of like peach tan color in cat kidneys, but dog kidneys should be dark red brown. And so whether or not there's just something going on that's preventing blood flow to the cortex, or changes in the glomeruli, but yeah, I think these are pale tan.
That's a really good point. Thank you. Alrighty, so moving on to the histology. This might be a little clunky. Hopefully it didn't sign me out. All right, can y'all see this screen now?
Yep, we can see it.
Awesome. So I guess I'm gonna just start. So these are two sections of kidney right here and here, and then I've got some more to show you as well. I should also say that I don't have TEM or immunofluorescence, and all of our sections are done on 5 microns, which I don't know. That might be a good discussion to have later on about how important the 3 micron thickness for staining is. But I'll start showing you some of the changes I saw. So already from the sort of subgross view, you might notice that there might be like a subjective reduction in number of glomeruli, or maybe the spacing of glomeruli. There's one here and then one here. But to me, it just felt like they weren't evenly spaced out like I'm used to. And then on closer inspection, there's actually early mineralization of Bowman's capsule already starting to form here. And then over here, this is really striking, but there is this proliferation of mesangium. So this glomerulus is touching almost all of the walls of Bowman's capsule, and you can't really see that urinary space at all.
That is a huge glomerulus. That is huge.
Yeah.
Is it 2 that are joined? No, it looks like it's all one single glomerulus.
Yeah, and look at this. So on higher magnification, there's actually these pigment-laden, I'm calling them macrophages, and I'm curious to hear what everybody else thinks of them. These pigment-laden macrophages that are sort of filling and kind of interweaving between the glomerular tufts, which is really, really striking and kind of head-scratching. And then I have some other great examples, best appreciated on the PAS, some of the other changes. So this is a PAS stain to stain the basement membranes. And I've highlighted some synechia. So you've got your glomerulus, and it's actually adhesed and connecting with Bowman's capsule. And then over here, I thought this was a good example of glomerular sclerosis, where you've lost sort of that cellular detail. It's shrunken. And then just showing some of the cortical changes here. I'm sorry, here. But you can see that some of these cortical tubules are sort of variably ectatic and thin-walled, and they kind of have this pink, almost proteinaceous material in there. And then in the interstitium in the cortex, there are these streaks and streams of lymphocytes and plasma cells, but also notably, if it's loading, those similar pigment-laden macrophages. So these macrophages are both within the glomerulus and within the interstitium. And then, probably unsurprisingly, but we've got this multifocal areas of mineralization all throughout both the cortex and the medulla. And then Mason's trying this kidney just kept giving. I was really excited about it. But we have these sort of streaks of interstitial fibrosis, which is highlighted in this dark blue color on this Mason's trichrome. So that sort of highlights a lot of the renal changes, but this case continued to give, and we looked at that stomach earlier, and so I wanted to show y'all that. So we have our superficial gastric mucosa up here and our deep gastric mucosa here. and hopefully you can begin to see, but there's sort of this fracturing of the mucosa and this sort of dark basophilic material. And it begins at sort of the mid-zonal mucosa and then also extends deep into the deep mucosa. So this is actually a really textbook lesion for uremic gastritis. And we've actually got mineralization of the mid-zonal and deep mucosa. And then all of this clear space corresponds really well with that edema that we were seeing grossly. And I was also reading that congested vessels, I might sneeze, sorry. Okay, we're good. Congested vessels are also a feature of this uremic gastritis. And then just kind of bring it all around. And this is lung tissue. But you can see there's this beaded fibrillar material, and there's some alveolar macrophages trying to clean it up. So we do have evidence of pulmonary edema. And then we have additional mineralization starting to happen around the main airways. So a lot of really great secondary, I guess, multi-organ lesions due to this renal disease. And we can zoom around the slides after, but just kind of bring it around. And I'd love some feedback on this. But for the kidneys, I called this a chronic severe diffuse because all the glomeruli I saw were involved to some degree, and then global because I felt the majority of the glomeruli were affected. And then I gave it membranoproliferative because we do have glomerular basement membrane thickening, but also mesangial proliferation. And then I don't know if this is an entity or not, but I just called it histiocytic glomerulonephritis. And then some of the features we discussed, but thickens Bowman's capsule, glomerular synechia, glomerulocystic atrophy, and sclerosis progressing to obsolescence. And then secondarily, I thought we had a lymphoplasmacytic and histiocytic tubulointerstitial nephritis, the mineralization, tubular ectasia, proteinosis, and interstitial fibrosis. And then the stomach and lung were secondary changes to this. And so in my endeavors to try to uncover these macrophages, I did read about a condition called histiocytic glomerulopathy associated with hemophagocytic lymphohistiocytosis. But I'm not convinced that that is what we have. And then I also looked into, I don't know if you could see it, but foam cells and sort of what they mean in renal disease. And these foam cells here, and I apologize for the quality of the photo, do appear to be somewhat pigmented, but it's really hard to tell with the staining properties. And so I guess I want to open up to the floor, but kind of where I'm at is I'm wondering, do we have an immune complex mediated disease? It's, to my understanding, we can't definitively diagnose this without immunofluorescence or TEM. I'd love to characterize those foam cells and what's also in them, what's staining. And I never did a Jones-Silver stain. And then, of course, it's a 1-year-old animal, and this sounds like this renal disease was going on for a long time. So I'd love to, if possible, explore a hereditary component. So that's kind of what I have for y'all. Hopefully that wasn't.
No, that was great. I'm Sean Spagnoli. I'm from Zoetis. So have you considered, and I've never personally seen a case, but that kind of golden pig, have you considered something like ceroid lipofuscinosis? Like, I don't know if it actually affects the kidney, but sorry, go ahead.
So this is, I have not seen this particular set of slides Peter had asked to present this case. And I think it's great because sometimes Becca Conkin isn't able to attend, but she is here right now. And we actually wrote a paper on this. So,
oh, cool.
No way.
This is glomerulonephritis, which I don't think is a good name for the disease entity, but it's what we had named way back in the 60s when we looked at a lot of these in like the, I was not alive, in the Beagles, like it was published as glomerulonephritis. And then we saw at the International Biopsy Service, the RVRPS, frequently. And those steroid, they're often either lipid laden or steroid laden macrophages. And so and I think on the trichrome, you can usually see them fairly well. You'll see a lot of those areas pop out in the glomeruli, which I think you showed very well. So yeah, if you like, almost all of them are completely blown out with.
Oh yeah, wow.
And then you can see like that bright red stuff is probably just a little bit of fibrin at the edge. And I even think, Becca, a couple of our dogs were young, small terrier breeds, to kind of say that there might be, I know bulldogs are predisposed. We had a lot of bulldogs in this cohort as well, but I think that's what this probably is. And there probably is a genetic slash dysfunction of the macrophage system. Some of these dogs, when we did collected more information, were had dyslipidemia systemically, but we didn't have a lot of people that actually told us what the cholesterol was or what the lipids were. We've some of these dogs were quite young, so I think it all fits together with that weird entity. And you also can just see this in beagles, like you can just see this in laboratory dogs, and it's usually. Yeah, oh yeah, it's fine. We should actually just show the paper. So I will see this because I see a lot of beagles these days, and like there might be 1 or 2 glomeruli that are affected with it, but there are many cases where pretty much every single glomerulus is affected with this. Yeah, I think that's exactly what you're showing.
That's impressive. Yeah, that's that's cool.
Yeah, and we actually showed that the more severe cases were actually more predominant in the younger population of animals too.
Yeah.
Suggesting that genetic component is important to the disease pathogenesis.
And they eventually have, exactly like you said, the secondary tubular interstitial stuff, like that comes down because the glomerulus itself is so distended. And we had EM on some of these. I'm looking at the paper right now.
Were y'all able to stain the fat, like the lipid?
So we did not for this paper. We didn't show the like oil red O. I occasionally will, because I get a lot of frozen samples that haven't already gone through tissue processing. So in the frozen samples, when I get them for immunofluorescence, I'll cut like 1 extra section and stain it with oil red O or Sudan black to show that that's lipid.
I believe that lipofuscin also lights up in PAS, but I'm not 100%.
It also autofluoresces, and since we get immunofluorescence on this, they all glow. So, and I think not Texas A&M, I think UC Davis and Peter Moore were looking at to see what kind of macrophages they might be, like what actual type of lineage of macrophages they are. And that paper that you just showed at the end of your presentation, kind of like the foam cell accumulation, that was one of our reference papers as well when we were talking about this kind of entity in dogs. So I think we see it more often than they see it in humans. It is something that I characteristically see in dogs, and I rarely saw it in humans. But I don't think that it ever came to publication. I did, Jessica and I sent UC Davis a whole bunch of cases and like case material so that they could try to figure out what the macrophage subtype was. And I know Kate Watson was working on it, but I don't think I ever got an answer. So I should probably reach out to her and see what the status of that was.
I'm just glad I can finally sleep at night wondering what those were. So thank you.
Oh yeah, so did you see any other evidence of like lipid-based disease? Did you see like atherosclerosis or any other kind of like foam cell accumulation in lungs? Like it looked like it was mostly the mineralization of the lungs. It didn't look like there was, like we were talking about, like a systemic lipofuscinosis or systemic steroidosis.
Yeah, I didn't see. We didn't have any. This was kind of the predominant lesion, and no atherosclerosis anywhere that we could see.
Any
but I
other
wish we had blood
questions,
work.
Dr. Shropshire? Let's see. I would think there'd be lipidosis. Yeah. Yeah, and the liver was fairly normal. There wasn't a lot of lipid change in the liver, or Dr. Shropshire from Colorado State is asking that.
Let's take a look together.
And I think that what Becca and I reported for glomerulonephritis, I think it is a huge spectrum, and there's probably a variation in how many have pure fat in the macrophages versus the lipofuscin / thyroid pigment versus how many glomeruli are affected. So I do think it's quite a spectrum of disease. And we just kind of gathered all of the cases that had been submitted in our biopsy service. So it looks like we had
30 or so, I thought.
Yeah, we did. Yeah.
And to
41
your
dogs.
point, definitely, not uncommon to see a glomerulus here or there in, normal, young, healthy beagle dogs, that this is a purely incidental finding, but that it can progress or become significant, as in this case.
And I think a lot of it too, like you can see the lesion, and then oftentimes you'll have, like you showed on your kidney slide, just a glomerulus that might just have sclerosis and not necessarily accumulation of foam cells. And it would be more common that you would see this in a patient that has podocytic related disease, as opposed to being present in a dog that has immune complex disease. There's a possibility, like you can see both findings. You can see ICGN and foam cell accumulation in the same dog, but it was more common to see them like a comorbidity of FSGS and glomerulonephritis.
Okay.
So.
But we don't know the significance really of those foam cells yet, or
I mean, we can say that they definitely damaged the kidney. I mean, that no matter what, the blood can't get through that capillary loop. So I have no qualms saying for your particular case, it's what was the inciting agent for the chronic renal disease. It also fits with the pallor of the cortex. So it was, but what caused the foam cells? No, I don't know.
Mm-hmm.
And in the scenarios where you just have one glomerulus that's affected, then it's probably just a degenerative lesion that like happened in that one glomerulus, and we can kind of, say, oh, well, one nephron got knocked out, big deal. But in your case, every single nephron was affected.
Well, that was awesome.
Rachel-
Thank you all for weighing in on that.
Rachel or Rebecca, did you guys have any necropsy cases from this, or was this all biopsy for your study?
Looks like they were all
I'm like,
biopsy. I'm
okay.
looking at my own paper. I can't. Yeah.
I was like trying to look. I'm curious on like other organs that could be affected. Like
Yeah, so when we have seen this disease in necropsy cases, I mean, like I said, if it's in the context of dyslipidemia, you can see atherosclerosis and hepatic lipidosis
I
and
don't know,
other
like when first will be done with
lipid
her
disorder issues, but
rechecks for me to talk about the two cases before I talk about owners, so it might be that I don't call them until we get all.
I think
Somebody's mic is on, and maybe
Update them soon, like, I'll give them a call. And just yeah, this out, so I might be.
I'm gonna try to mute Emily.
I usually say by the
Here she is.
Okay, yeah.
Okay, that's be fine.
I'm just really happy it's not me this time.
Yeah.
sorry,
so it
Sarah,
looks like
yeah.
we had some, most of them were diagnosed that had this lesion were in either stage 1 or like iris stage 1. They weren't, severely uremic. We did have a couple of dogs that were diagnosed late stage, which yours was. And the ones that were diagnosed late then progressed pretty rapidly. Because even though we had 40 dogs in the cohort, we only got follow-up from like 5 of them. And this was also kind of in 2017, so we were not probably as aggressive about asking for follow-up data as we have become now. But
Okay.
it's it is a subtype of disease that we even sort on our database now, like we sort for glomerulonephritis. So, and I see it, like I said, usually I will throw it in a diagnostic line if it is repeatable, as in your case where it is repeatable. I would just call this glomerulonephritis or nephropathy characterized by glomerulonephritis and then list the secondary lesions. And honestly, if you want to do a Jones, that's great. If you have unprocessed renal tissue, you can try the Sudan Black or Oil Red O just to see how much lipid versus steroid it is. Usually, from my understanding and remembering back to GenPath, like to tell the difference between steroid and lipofuscin, you kind of need to do a lectin staining, which I don't think anybody does. Does anybody do that differently in ToxPath now, Becca? For like lipid versus steroid, or sorry, lipofuscinosis versus steroid?
Not frequently.
Yeah, I mean, it always just said in the textbooks that you would have to do a lectin stain to figure out which was which, and whether or not that is even worthwhile.
Yeah, I don't think we see it frequently enough to have a standard approach.
And the disease entity that that Sean was talking about is the concept of like systemic steroid-laden macrophages. So you see it in the brain, you see it in the gut, and that's kind of a different scenario. So cool. Any questions from the clinicians? I mean, I don't know how many times you guys have sent a biopsy that maybe has had this diagnosis and what you guys think about it clinically. Like, how would you provide, or what would be your treatment goals for this? I mean, yeah, Dr. Baden's definitely biopsied this. Besides, okay. So we have, if this came through renal if it was a biopsy, the dog was still alive, seeing if it's dyslipidemic, and then do RAS inhibition. Anything else that you guys would suggest?
I think that's reasonable. I don't think we ever really know what to do with these. I don't think we necessarily know, understand them well enough. So what Jenna is suggesting seems very reasonable.
Okay.
I was trying to find the case in our Easy Vet medical records, because none of us are familiar with it. So maybe at some point you can send us the case number or name.
Yeah, I wasn't sure if I should put the information on here,
Well,
but I just put it in the chat for you.
We're curious. That's perfect. Thank you.
Yeah.
Yeah, and so your history did sound like basically it presented kind of in distress and they euthanized and didn't get any information, correct?
Yeah, was my understanding. I think it came in as like a last ditch effort. Like, I think they had been managing it maybe with their primary veterinarian for some time and came into us.
Cool. I mean, sad for the dog, but and I like I said, as Becca had stated, the ones that had really bad prominent lesions in a large portion of the sample were usually young, whereas if they only had 1 or 2 glomeruli affected, they were quite old. And so that's probably just the run-of-the-mill degeneration that you could possibly see. But if the situation is right and it knocks out all the nephrons, then obviously the dog's going to present much younger. Alyssa, you have a bonus case. Do you want to quickly go through that?
Yeah,
Let
sure.
me ask a question or two.
Sorry, George, Dr. Lees has a question.
Is this an NCSU case?
It sure is.
From the perspective of it being a very young dog with very advanced lesions and things like that, and one of the things you asked in your presentation is about the possibility of hereditary. From my perspective, I'm unaware of any well-described, well-characterized hereditary example of this in dogs. Okay, the question comes up, but in terms of knowing that there's a hereditary, truly hereditary or familial form of it is an open question. You have to think about it, but what I wanted to say is that from my experience, you end up trying to find out whether there's any family history, whether you can get any information about parents or first order relatives, siblings or half siblings, things like this. And oftentimes you can't, or the breeder doesn't want to talk to you about anything wrong with their dog, or it was actually a rescue dog or something like that. It's a total dead end. But every now and then, turns out if you ask the right people the right questions, you open the door to a lot of possibilities. And so my suggestion is at least try to find out a little bit about the origins of the dog, Are its parents known, the breeder known? Are they interested in telling you anything at all about other family members, and probably at least screening them for proteinuria and or azotemia, or for that matter, peripheral circulating lipid disorders. And, you know, then sometimes, as it turns out, you hit on, an opportunity to follow up on something that actually leads to productive understanding of a disease that was formerly misunderstood or not understood at all.
That I think that the propensity to say, since it's a young dog, obviously there could be something in the litter. It's easy enough for me to ask. Like I will even put on my biopsy comments, like, you know, knowing whether or not there was litter mate affected can be helpful. And then obviously looking and testing the parents to see if they have evidence of proteinuria. Like UPC is so easy to do, and it's so non-invasive, or an SDS page is so non-invasive that it makes sense to at least try to gather as much urine from related dogs to then try to identify who else could be similarly affected. So it's a lot easier than a renal biopsy, I will admit. Okay, cool. What's the bonus case?
All right, this is another NCSU case, and it's a well-known one, and I don't have as many. It's just a G-Wiz, I guess. But this was a 5-year-old female spayed Labrador Retriever, presented to RDVM with dolomentation, seizures, and ataxia. The housemaid had died from acute kidney injury in the past, and there was a suspect ethylene glycol intoxication. It was referred here. It was comatose. They did some blood work, and they had a greater than 17 lactate, acidosis, and then a hypocalcemia. And overall, the owners declined treatment due to the poor prognosis and elected to humanely euthanize. I'm just going to skip through this stuff because it's not that important. But here are the 2 kidneys, and I had read online that in really acute ethylene glycol toxicity cases, you could actually fluoresce the urine. And so I tried to do a Woods lamp, and it made a cool picture, but it is non-diagnostic for sure. But we did do a urine sample. You can actually see these beautiful monohydrate crystals. And then on the stain section, you can just see how many there are. It's actually sloughed renal epithelium throughout here as well. So here it is on higher magnification. This is a lot of crystals. And then on histology, you can actually see the crystals in the tubular epithelium. So really beautiful example of ethylene glycol toxicity and the crystals that form. And then I can't figure out how to take a photo on a nice camera, so I had used my phone, but you can just see that this is the tissue under polarized light, and it looks like a night sky with all the stars lighting up. So these are all the polarized crystals. So just a fun G-Wiz case and reminder about ethylene glycol toxicity.
And so they knew the other dog as well had been.
Yeah,
Like,
this
there was a
became a
dog in the household?
pretty big legal case.
Oh, ooh.
Yeah.
How long before this one was the other dog diagnosed?
I think it was all within like 24 hours. So
Yikes.
yeah.
I had read, gosh, like this is now making me think. I will send it to the group. There's a really cool thing about oxalate metabolism. I don't know, that's a weird phrase to say, but like because like it is only stuff for us to do because we have the propensity to eat meat. We should be better at oxalating like metabolizing oxalates, because it would and so therefore, because humans don't actually have that metabolic system as easily as other, I'm going to find it again, But anyway, point being, the culmination of it is that maybe we were more vegetarian when we were evolving because we don't have nearly as good of a system of digesting oxalates as people as pure carnivores. I'll have to find that again. Anyway, it was interesting. So that's a classic oxalate case. Any questions from the clinicians about that? I mean, I guess, do you guys, if they come into hospital and you are managing them clinically, you guys are just looking at the urine and then doing the standardized treatment for it?
Those kidneys are dead forever.
Oh, okay.
That
Just because of
actually,
how much
as an
work
aside,
went there?
some of the first clinical efforts to do renal transplants in dogs that I'm aware of were in young adult, otherwise perfectly healthy, nice dogs who abruptly got ethylene glycol and dead kidneys. And you know what better candidate to try and find, you know, without comorbidities to save its life with transplants. And I remember Dennis Chu telling the story of his work with a couple of those such dogs back in the day. But
Okay, I can quickly show a Zoetis autopsy. I asked the permission from the clinician, and she was hoping that this would be, if we could discuss it, and maybe she could learn more for the case as well. Thank you so much, Dr. McGinn, for presenting. And like I said, anybody who wants to be involved in presentation, whether you're coming at it from the clinician's aspect or from the pathology aspect, then just let me know. I'm going to share my screen. If I can make sure, as you said, logged in.
That was a lot of fun. Thank you. And thanks for helping me solve the case.
Yeah, I would have glomerulonephritis somewhere in there, and then that way, and like I said, as you look more and more at beagles, especially if you're looking at some of those Dr. Nichols beagles, you're going to see one or two of those glomeruli that are affected with the lipidosis. It's just such a common lesion in beagles that there it is. It should be fine. Okay, you guys should be seeing a whole bunch of organs. Yes, you are. Okay. So the history I had from this was actually no history. It was an autopsy in a bottle, and I called the clinician because I was confused as to what I was supposed to be looking for. So I'm gonna go to the kidneys. So I was able to speak with her, and she said the dog had presented. We do have at least breeds. Like, what do we have? We have a 2-year-old. She said he was or maybe 2 or 3-year-old. She said he was a gorgeous Doberman Pinscher. He was just beautiful and he was super nice. They live in Texas, if that tells you anything. Texas A&M people. And you know, they didn't get a lot of that much information from the owners other than he was vomiting and like bloody diarrhea, vomiting for maybe a couple of days, and they had brought him into the clinic. They did basic blood work. His creatinine was unreadable. It was so high. And otherwise fairly kind of not much else like signaling like what was going on with the dog. They gave the owner didn't really want to do much. They gave the dog some fluids, sub-Q fluids. The owner took the dog home. Dog didn't improve, so they brought him back the next day, tried to give him IV fluids. Dog never made urine apparently at all. And so they eventually, the vet recommended euthanasia for humane purposes because the dog just was progressing pretty rapidly. And so, and the only other thing that she mentioned was that there was a wound on the top of the back that had been there when the dog first presented. It was a pretty small wound. An abrasion, and then by the time the dog actually got rehydrated, it became super edematous, and that's not where they gave fluids to either, but it became super edematous and like oozy and like necrotic. So I leaned heavily on my derm people to help me figure this one out, but hopefully you guys are seeing an HV of a kidney. Let me know if I'm wrong. And all of the tubular epithelial cells have some degree of degeneration and or loss, necrosis, and there's a lot of tubular casts within the renal cortex, and then also extending partially down into the renal medulla. There's a lot of kind of heme pigment associated with it as well. I think this is mostly heme pigment in the degenerating epithelial cells. And there's also some degree of just regular protein leakage from the glomeruli. But anytime you see small amounts of nuclear debris, these are dead cells, then the rest of the tubule that's hanging on for dear life has attenuated epithelium. We even have one cell over here who's probably trying to regenerate, but they've lost their good brush border. And it's very prominent throughout the cortex. The glomeruli themselves probably are a little bit leaky. I wouldn't be surprised if we saw some podocyte injury. If we had done EM on this, I wouldn't be surprised if we had a little podocyte degeneration and injury. But they don't look that bad. I'm not like really like thinking about an immune complex disease or anything. So hopefully all of these things are catching your eye. They go further down, get a little bit even more compacted into the medulla portion. So you could see that if these guys are hanging out in the collecting duct system, that it's going to be very difficult for urine to exit the kidney. And so that's probably why the dog was oliguric to eventually anuric. So it was a very prominent lesion. And for any pathology trainees that are listening or calling into this, like this should strike you as severe acute tubular necrosis. One thing that I'm surprised we don't see is I'm not seeing a lot of interstitial edema. Usually with really bad acute tubular necrosis, we'll have a lot of expansion of the interstitium just from edema fluid, and I'm not really seeing that, but again, the dog had been severely dehydrated at one point, so maybe it just hasn't gotten to the point where it would have the amount of vascular fluid to be that leaky. Any questions about the histology portion for the kidney? Okay. Ooh, look how cool this is. Like this is a sloughed like this was one whole tubular epithelial cell raft that like just detached as it is and is now coming down the tubular epithelial cells. For pathologists, if you see maybe like, let's say you had a case and you only saw like this degree of injury where you had like, oh, maybe these are slough cells, but then again, could it just be debris? Like, I'm not really sure. Sometimes the autolysis would be prominent, or a differential, I guess I should say. So one, we prefer to use the PAS stain, which I did not use on this case because it was so striking. But the PAS stain is going to show us that even on the tubules that are only mildly damaged, you don't have any more brush border. The brush border is gone. So the first thing to leave the brush border is, the first thing to leave in acute tubular necrosis is that the tubular epithelial cells slough their brush border, because it's a very high energy maintenance for the epithelial cell. That brush border is very complex and it has a lot of transporters. So they have to work so hard to maintain that brush border that their first attempt to survive is to get rid of the brush border. So this tubule that I'm showing here really has no brush border left. And he would have been a straight portion of the proximal tubule. So he should have brush border, and there it's gone. So you can use the PAS stain if you're on that questionable on the fence, like, is this really ATN or not? And that's, one of the things I look for is to find absence or presence of the brush border. The trichrome stain can also show the brush border. It's kind of a red color because there's so many proteins there. But I like the PAS stain the best. So
Rachel, with autolysis, would you also lose the brush border?
It wouldn't be specifically detached, and it wouldn't be this extensive. And so that's always like the question that people ask, like, oh, well, if it rots, like, would it be bad? Like, if the whole thing is rotten, then, you can definitely see like there's no residual identifiable cells. But I think I've seen enough times where it's like, oh no, I could still tell that there was tubular epithelial injury. Obviously, knowing the postmortem interval also helps.
Yeah.
I think it's also helpful that you have like, you know, in any given field, you have tubular epithelial cells that look okay.
Right.
And then you have tubular epithelial cells that have, you know, hypereosinophilic cytoplasm and pycnotic nuclei, and they're in various stages of detachment, and you have frank apoptotic cells. And so there's kind of a spectrum of degeneration necrosis that cues you into a real lesion.
Yeah.
Yeah. And this tissue does look pretty good. So they must have collected pretty quickly.
Yeah, she said they
after.
euthanized, and then they because they immediately went to autopsy because they euthanized the dog. The dog didn't just die on its own. So she would that, I mean, even like the fact that I didn't get any information at all in the history and I had to call, and she was super nice. She was just like, oh, I'm really sorry. Like, we needed to make the shipment date or whatever. I wanted to get it to you guys. And so I was writing furiously down, and then I eventually was like, can you just email me the history so that I can add it to this record? Because I was like, I didn't know what to make of the skin wound. And I was like, well, if it was on the back, maybe it's like an abrasion from like the harness or whatever. Cause she's like, the owner, the dog, I was going down toxicity route. So I was like, well, what did the dog get into? She's like, the owner said that they are pretty good at monitoring the dog. The dog does have outdoor access, but they're pretty good at making sure, like, you know, they have an eye on the dog. And she's like, but it is a Doberman, it's a big dog. And so I was trying to figure out like what toxins. I was going down like vitamin D, cholecalciferol, but like nothing else in the body was mineralized. Oh, sorry. The heart was mineralized. I will show back at the heart because she's our heart person. The heart was mineralized, but the lungs weren't mineralized. The GI tract wasn't mineralized. There was no mineralization anywhere else other than the kidney and the heart. And the heart, I'll show you next. Becca's gonna be super excited. So you get these foci, and they're throughout, they're transmural, they're not just subendocardial, and there's just frank mineralization of the cardiomyocytes with degeneration and necrosis. And it was, like I said, patchy, but throughout the whole aspect of the heart. And they sent a lot of samples of the heart. She did see kind of white plaques when she did the autopsy. And so I was like, well, uremic endocarditis, but it's not really endocardium. Like, it's not, you know, and it's not really inflammatory. It's totally mineral. It's like, you know, it's basically very even difficult to cut because there's so much mineral. Let's see, where was the other part? So anyway, here's more little spots of it. So then the part on the skin, there is a region of hemorrhage and necrosis. It kind of almost goes full thickness. And then I was able to email, I think Sean got back to me and Keith got back to me, and they're like, I was like, could this be like a snake bite or like an envenomation site or like a wound from like a spider? Because I've had a case where a snake bite caused severe acute tubular necrosis with that degree of mineralization and had myonecrosis. Now it had necrosis of the tongue. It didn't have necrosis of the heart. The dog survived. It was a biopsy. And the dog was dialyzed pretty fast. But they were like, yes, I think this wound definitely fits with that. And you can see how necrotic the vessel wall is.
Yeah, I had a case where we had, when I was a resident, it was a miniature donkey that got a rattlesnake bite. And actually, I would say this dog must have died pretty quickly, because by the time the donkey died, like, it was melted. Like, there was no tissue left to see. So this is actually super well preserved for a necrotizing toxicity. The other, which was also why I was thinking maybe brown recluse, but my own stupid dog likes rolling around and got a brown recluse bite, and they necrotize like right away. Like, they're sterile, they don't smell, like, so, and the location of the injury for like a dog rolling on its back, and the fact that it's like a single wound and not like a bite. I don't know, like, rattlesnake would, it seems weird that a brown recluse would be able to kill a dog but if it's, I don't know, like, it just.
Well, and even there are case reports of scorpion stings being
Okay.
and it's Texas. So literally all I ended up with was it's Texas. So there could be anything hiding out in those woods.
Texas is just like Australia for America. Like, who knows what's going on there? Like, yeah.
But yeah, I mean, I think it at least gave the vet a way to connect what was going on, because the skin was the only thing that she saw at the beginning, and she knew the dog was severely azotemic. And then as it did live it had 2 days of vomiting and diarrhea, and then she thought for 2 days. So it had lived for 4 days. And maybe it was only a partial envenomation, like maybe it was mild, but it still was enough to kill the kidney.
Were there coags taken on this animal?
No, not in the history she sent me. She had had a CBC, and there were platelet clumps. I do remember that.
You know, the other thing that I'm thinking about as we're talking is it's also possible there were multiple bites and we only just saw the one.
That's
So
true.
it's just because that's the only skin we're seeing where we actually saw a bite, it's possible that the animal got a lot more venom that we can't correlate with an external wound.
And I think at the end, like for the people that are like nephrology people, I wanted you guys to see that severity of the acute tubular necrosis. Like I said, the dog was not making urine, so we couldn't have looked at a urine sediment to see the tubular casts. There was no theory, like clinical theory of snake bite / envenomation / scorpion, whatever. This all came after the autopsy. But I at least gave the family a little bit of closure. Like the fact that the heart was so mineralized, this dog was like, the euthanasia was pretty much the only option for this dog. Like even if they had had the money to pay for dialysis to survive the AKI and regenerate its kidney, its heart's going to be scarred.
And actually, I also it's interesting that you mentioned that there was no clinical suspicion of envenomation, because the envenomation cases that I have had have presented as found dead. And so that's actually it makes perfect sense to me that there's no clinical suspicion of envenomation, because these animals, they get bit, the animal probably doesn't even realize what happened until it starts crashing. And so there's nobody notices it. So it's a very common, at least in my experience, for envenomation cases to not have that suspicion at all, because nobody actually witnesses it happening.
Yeah, exactly. Texas people, do you have any defense of your state?
I was just gonna say, when I was an intern, the few snake bites
Absolutely not.
had actually did come in with a history of snake bite, oftentimes with the snake in hand. That is Texas for you.
If they grab the snake?
If
Hell
they
yeah.
could.
Grab that
And then
snake.
Jessica adopts it and she takes the snake home.
It's mine now. I keep it.
Goodness gracious. Okay, so for the clinicians that are attending, you saw a great classic oxalate case. You saw a classic ATN. That ATN is so beautiful. I think I guess one other thing that I didn't share about the skin part. Am I still sharing my screen? I am. There was bacterial proliferation, but it was on the dead tissue. So originally, being not a non-dermatopathologist, I saw all these bacteria and I got excited. And then I was like, wait, I don't see any inflammation reacting to them. This is just bacterial colonization of dead tissue. Now, what were the bacteria making? Were they making any kind of endotoxins? Possible, but I wasn't focused on how bad the walls of these vessels looked until Sean and Keith were able to help me with that. So.
Oh no, that was all Keith. That was all Keith. I just wrote on his coattails and said spider. That's all I did.
Good to have specialists. And then we will reconvene next month. Looks like the date. Let's just make sure I'm in town. Hold on. What would it be next time? July 18th. Okay, that should be fine. And we'll send out invites or case requests email beforehand. And I think, if you ever want to present, you can do an amazing PowerPoint presentation like we had today. You can also just fly by the seat of your pants like I'm doing right now and just showing a fun case. It's just mostly to make sure that we get a wide set of participants and it's not just me giving a lecture. I like to be able to discuss cases and kind of learn from what other people are also saying. So
There is a very quick discussion about the mineralization and how fast it has occurred, and a response from Becca about pathologic calcification with dead, dying myofibers. So just wanted to throw that out there.
Oh yeah. I think that's exactly true. It says I think that the ions can precipitate pretty fast. And also one other thing I was going to say, Dr. McGinn, is that mineralization, like another helpful point for you as you start to read more and more kidney cases, is when you see mineralization to that degree of the tubular basement membranes and even Bowman's capsule basement membranes, it's always a poor prognostic. Every time I get a biopsy that looks like that, I'm always like, it's not going to go well. And I've never published like the score of mineralization. I think we're kind of working on a project for a different set of cases, but like, I've never been able to say like, yes, if you have this degree of mineralization, the literature says you will die within 48 hours, but it is my anecdotal memory of they don't do well. I do, if I have a biopsy that has that degree of mineralization, I will tell the clinician that like, you know, that you either need to act fast, like if we think it's immune mediated, or, you know, just tell the owners that it might be a losing battle.
Dr. Cianciolo, is that in reference to the glomeruli specifically, or are you also including tubular mineralization?
Tubular basement membranes, when it not like, if you see it in 1 or 2, it's not that big of a deal, but when you see it as much as it was the case that he was presenting, so Bowman's capsule basement membranes, tubular basement membranes with, you know, a moderate degree, I have seen mineralization of the glomerular tufts as well. I have a really cool amyloid case that mineralized the glomerular tufts, and that dog died within a day. So that's always a good thing to have in your back pocket. Like if you see a lot of mineral, be like, I don't really know how this is going to go. And at least that way the owner has a little bit of idea of like closure of like, okay, I made the right decision to euthanize the animal. And it kind of gives them a little bit of like peace of like, I did the right decision. Any other questions?
That's really helpful because a lot of times we'll see like medullary or papillary mineralization from animals that have leptospirosis, from sea lions, from leptospirosis, and a few of them also with NSAID toxicity. And of course, all of those are like, they go downhill pretty fast, but yeah.
Is that
I would
different though?
say-
Because I see papillary mineralization with
That's
dehydration
different. So
all the time.
Yeah. Papillary, so
Yeah.
actually within the lumens isn't that big of a deal. I should have been clear about that. Like having mineral casts, like a little bit of crystalline cast in the renal papilla, that's fine with me. I think that stuff is on its way out.
Okay.
It's when you see the basement membrane. So basically think about the cell having mineralized, and then it basically is precipitating along the basement membrane of the tubules. That's when I start to worry.
Okay, cool. Thank you. Thank you.
Yeah, and Becca's right. Like I see, I'm scoring a whole bunch of kidneys, and there's
All the
always like
time.
5 or 6 like little casts. I've actually heard some people talk about how they would use that. Like I was speaking at Cornell, and they were talking about how they would use that papillary mineralization as evidence that the animal died from dehydration. And I was like, no, you cannot use that as a definitive evidence of dehydration. Like if you see fulminant necrosis, papillary necrosis, that's different. But if you just have a few casts in the papillary collecting ducts, like that's just a normal thing. So
Okay, good, because I was calling it incidental, and then I was
yeah,
like,
those are
oh.
incidental. Just in the collecting
Yeah.
ducts, in the renal medulla papilla, that's fine.
Okay.
But when like the whole papilla is necrotic,
Right.
or mineralized or detached or whatever, then I'm
Okay, so just the basement membranes. Thank you.
Everybody good? Okay, well, we will reconvene next month. Thank you guys for a great set of rounds. Everybody
Rachel.
give Dr. McGinn a hand for being so bold and brave.
Thank you. Good job.
Okay, I'm gonna end. I have to go to another meeting, so I will see you guys soon. Bye.
Bye.